Thanks for coming out tonight. I'm Joan Galbraith. I work in the health service. And this, Kendra and her Drew Health Organization helped put together this women's health panel for this evening. So this is Dr. Rubino and his colleagues, and I'll let them all introduce themselves individually. But just to give you an idea of what we'd like to do this evening is they'll start with their PowerPoint presentation, just go through some basic women's health topics and go through each of those. Afterwards, open it up for questions. This is your opportunity to ask anything you want about women's health, so don't be shy. We do have on the back table some index cards and pens, so if you don't feel comfortable raising your hand and asking a question, please write them down and put them in the basket, and we'll go through those at the end as well, okay? And there's pizza, plenty of food back there, so help yourselves and enjoy.
Thank you, Joan. And thank you for inviting us here tonight. Welcome, everybody. This panel is of our colleagues. To the far left there is Dr. Lisa Abisaus. She's a graduate of Dartmouth Medical School and St. Luke's Roosevelt for her postdoctorate training. And next to her is Dr. Priya Patel. She's a graduate of Stony Brook Medical School and did her training at the University of Pennsylvania. And sitting next to me is Dr. Anne-Marie Tang, an alumnus of Drew University, and also of my medical school as well, New Jersey Medical School in Newark, under the Rutgers banner. And I'm Dr. Robert Rubino. So thanks for coming out tonight. We're all obstetrician gynecologists, and our field is somewhat unpredictable, which would explain the absence of two of our physicians. One got the flu this morning, and the other one is now catching some babies over at St. Barnabas. So I will be picking up the slack for them on their PowerPoint. And tonight is meant to be somewhat informal, so there'll be a little bit of PowerPoint and maybe just some dialogue between the panelists. And we invite you to write your questions down and pass them in. I think it makes it a little easier for folks who may not want to raise their hand and ask a question that might be a little bit worrisome to ask in a public setting. And we will invite you, if you're fine with that, to just raise your hand and we'll do our best to answer it. And hopefully this will be valuable for you. I understand we have how many pre-med or healthcare students do we have here?
Oh, wow.
Okay, I'm warmed to see that interest. And who knows, maybe there'll be more after tonight. So tonight we're going to get started. First, I'm going to speak a little bit to my colleague, Dr. Priya Patel, who has an interest in HPV or human papillomavirus. And Priya, maybe you want to talk a little bit about what is HPV and why does it matter?
So HPV, it's short for human papillomavirus, and it's a sexually transmitted virus. It's extremely common, and it's important because it can cause various diseases, some of which are commonly known as genital warts or certain types of cancers of the cervix, of the penis, of the vagina. So HPV is the virus that is linked to those things.
I'm sure there's folks sitting out there, not only here in the audience, but out in the general public saying, well, how do I know I have it?
For the couple of boys that are out here, there's no test for the boys, but for the females, we recommend that every woman gets an annual exam, and starting the age of 21, we do something called a pap smear, and the pap smear tests for changes to your cervix that, and also changes that would be related to HPV, and sometimes even directly tests for the HPV virus.
So if there's folks here Googling HPV right now and you see that it's coming up with 150 plus versions of it, are there any versions or types of HPV that matter more than others?
Yeah, so if you do Google, you'll see like well over 50 types, and they all are linked, like little kids get hand warts and things. These are all linked to HPV. The ones that we're sort of focusing on, there's a couple that you might see come up on Google, 16 and 18, and those are linked to cervical cancer, actually linked to about 70% of all of the cervical cancer worldwide is linked to these two types. So those are, I would say, the high-risk types. There are a couple, 6 and 11, that are linked most commonly to genital warts, and again, about 90% of genital warts come from the type 6 and 11. So there are certain types that are, more consequential than others.
Since, it's a sexually transmitted infection, I think some folks might have concerns about public facilities, locker rooms, borrowing a roommate's towel, what we call fomites. Can you speak a little bit to fomites and transmission of infection?
So this is, again, a sexually transmitted virus. It's from direct skin-to-skin contact or intercourse, including oral intercourse. It can cause oral cancers as well, but you won't get it from a public restroom or from sharing a towel or something like that. It's direct skin-to-skin contact.
Typically with your patients, what's your advice as far as prevention, and what conversations do you have about condoms as it relates to HPV?
So I always, in my opinion, say condoms are a good idea because it's the only thing that really prevents STDs. HPV, it can help prevent some part of the transmission, although the condom doesn't cover all of the skin. So because you can transmit HPV from just direct skin-to-skin contact, it's not going to be 100% preventative. So there are vaccines that are available that come to close to 100% prevention of HPV, especially if you get it before you've become sexually active. But even if you're already sexually active, it still can help prevent a lot of these high-risk types that we were talking about earlier.
You bring up the point of the vaccine, and probably some folks in the audience have had the vaccine, others may not have. And I think not justified, but there's a lot of conflicting information about vaccines and how good they are or not, or risky. What's your opinion and advice about the HPV vaccine?
In my opinion, it's black and white. It's a good idea to get it. The vaccines have been, over a lot of research, over a lot of people who've had them, been shown to be safe. They're tolerated well. Some people get like pain where the vaccine was for a day, or sometimes people get a little muscle ache there, but there isn't any serious side effects associated with it. And the benefits are very real, which is close to, like I said, if you've never been exposed to HPV, close to 97 to 100% prevention of some of the types that we talked about. Almost 90% of cervical cancers are caused by some of the 7 that I listed up on the slides. And that the vaccine that's available in the United States, as of 2017, covers 9 of those types. So that would, in my opinion, it's clear that it's advised. And it's for women girls starting the age of 11 to 12. So a lot of pediatricians will have given it to their patients before they even come see us. But if you haven't, up until the age of 26, you can get it, and it's covered by insurance until then.
Yeah, I think I would even go one step further in that I think the HPV vaccine is to cervical cancer what the polio vaccine was to polio. And it could, in a generation or two, wipe out cervical cancer in industrialized nations if it's a well-applied public health strategy. But really is a remarkable vaccine and remarkable progress in our field in the last 15 years. Thank you, Dr. Patel. Now, next we'll move to Dr. Lisa Abisaus, who will talk a little bit about going to the gynecologist. Nobody likes to go, although we do our level best to make it as benign an experience as possible. Part of being here tonight, we're a local OB/GYN practice. We have an office here in Madison, and we really are trying to be more engaged in the communities that we serve. So this is part of it, and hopefully when you come in for a checkup, you'll feel relaxed and comfortable in the environment. And somebody like Lisa, who's also a mom of 4, is very good at that. And I'll start with the first question. Lisa, what should anybody expect when they come for their first GYN exam?
Okay, so when you come for your first GYN exam, there's actually a lot of talking that goes on. There's a lot of misconceptions. People think it's going to hurt. Everybody's nervous. So if you feel like you're going to be nervous, you're not alone. Everybody's nervous. But we really do a lot of talking. We really want to know about you, your family history, your medical history, your menstrual history. How old were you when you first got your period? Do you have any period problems? Painful periods, heavy periods, irregular periods. So we really want to get to know your history in terms of that. And then, of course, we do a thorough exam. We start by doing blood pressure, just like you're used to at your typical doctor's visits. We listen to your heart and your lungs. We do a full checkup. We obviously focus on the female part, so we do a full breast exam, and we'll teach you how to do the breast exams at home. And then we get to the pelvic exam, which is the part that makes everybody nervous. But we talk you through it. We'll let you know what's going on, and it really doesn't hurt. We use what's called a speculum to visualize your cervix and visualize the walls of the vagina. And it goes in and it does feel like pressure. It shouldn't feel like pain. Mostly feels like pressure, and that's also how we get your pap smear, which is a screening test for cervical cancer. So that feels like a little bit of a poke, but once again, not really painful. And then we'll do the bimanual exam, which allows us to do an internal exam and check your uterus and your ovaries. And then, of course, there's always time to explain what we did, as well as take questions and come up with the plan for whatever counseling is pertaining to you.
So I'm a 19-year-old female college freshman, never been sexually active. Is it time for me to go to a GYN at 19, not sexually active?
Yeah, absolutely. Yeah. 19, whether you're sexually active or not, is really the perfect time to come. Even if you're not sexually active, as I mentioned before, we really want to talk about your history. We're going to talk about cancer prevention. We're going to go over family history in terms of your risk for cancer. We'll talk about, in the future, if you're anticipating becoming sexually active, how to prevent STDs and how to prevent pregnancy and how to keep yourself safe. So that would really be the perfect time to come.
Is there any tips you would give people to prepare before they come?
Basically, you really want to know your family history, so ask your parents, your grandparents. It's important to come in with that information. We're also going to be asking about your menstrual history, so if you have problems with that, whether it's painful, irregular, heavy, those are the things we're going to want to know. There's also some misconceptions about shaving and waxing, and honestly, we don't care. So if you do, that's fine, and if you don't, that's fine. So either way, we are able to do what we do and that doesn't get in our way, so that's fine. And one thing to keep in mind is if you're just there for a regular checkup, try not to be on your period. If you're having bleeding issues, that's different because you can't anticipate what will happen. But if you can predict, then it would be better not to be on your period.
Can you explain, because sometimes there's a nuance only maybe physicians know and patients don't know. What's the difference between a checkup and a problem visit?
So the checkup is really the well woman checkup, where we go over your risk factors for either STDs, cancer. That's basically the well woman checkup that we do recommend you come once a year, every year, starting now. And the problem visit really focuses in on if you're having a problem, whether you might be having vaginal discharge that smells bad or is itching, then we'll definitely focus in on that and figure out what's going on and come up with a plan for treatment. Or if you're having problems with your period, that becomes a problem visit because we want to get to the bottom of it and come up with a plan for treatment with that as well.
There's sometimes people have to come in and explain what's going on with them. Can you give some tips to the audience about how to be kind of a good medical historian as a patient?
Mm-hmm. So it's really important, number one, just to be honest with your physician. Keep in mind that everything you tell us is confidential, and we wouldn't relay that information to anybody else without your permission. So it really helps us to get to know you and to be able to come up with a plan if we have all the honest truth that goes behind it. So that really is the most important thing, that don't leave anything out. Let's say some people come in with the parent, which is great. We want to get your parents' perspective and allow your parents to talk, but we always give you time for the parent to step out of the room so that we can just have the personal one-on-one, and everything is confidential.
Thank you, Dr. Avicel. So contraception options available. So there's the barrier method, which are things that block the connection between a sperm and an egg. So that's diaphragms, condoms. There's oral contraceptives, and those basically are medicines or hormones that prevent the body from letting go of an egg or ovulating, and it kind of disrupts the communication between the ovaries and the brain. And that's how it works, kind of fakes your body into thinking it's pregnant. Alternatives to that are the Xulane patch, the NuvaRing, and Depo-Provera, basically hormonal means of contraception, but not through a pill. Usually it's Depo-Provera is an injection. You get it 4 times a year. The NuvaRing's a little flexible ring that women slide inside the vagina, and it stays there for 3 weeks. They take it out, they get a light period, and they put another one in. Again, if you have memory issues, you have a busy lifestyle, these are great alternatives where you just, kind of use it and go. And then LARCs, or long-acting contraceptions, which are basically things like IUDs or intrauterine devices. There's several listed there. Those are the brand names: Mirena, Kyleena, Skyla, Paragard. Nexplanon is not exactly an IUD. That's like looks like a little matchstick that gets injected under the skin, and then it gets removed once it's done. I don't know how long does that last for, the Nexplanon, 3 years? I'm not a particular fan of that, although Dr. Saida, who wrote this slide deck, is a big fan of that. I just, don't like the concept of having something underneath my skin, but lots of women love it and swear by it. So there's a panoply of options when it comes to contraception. This is the barrier methods. You can see there on the top, those little donut-shaped domes. Those are cervical caps, diaphragms, if you will, used with spermicide. A woman inserts it into the vagina, and it blocks the cervix, which is where sperm would go through the cervix to impregnate a woman. I'm personally not a big fan of that. They're kind of messy. They work well, but not as well as the other forms of contraception. But some women, it works well for them. So it's individual preference. A little higher failure rate as well, which, when it comes to something like contraception, I want the highest efficacy I could get. So oral contraceptions, they've been around for over 50 years, one of the safest drugs on the market. And as I mentioned, they basically fool the brain into thinking the body's pregnant. It prevents ovulation. There's lots of different options. They have side effects in the first 3 months, maybe some mixed up bleeding when you're not supposed to. We call that breakthrough bleeding. Sometimes some breast tenderness or some irritability, sometimes a few pounds of weight gain, but not too much with the modern pills. The most significant side effect is a deep clot in the leg, which we call a deep venous thrombosis, and that can break away and go to the lung or the heart and cause significant complications. It's an uncommon event, but it's more common on a woman on the birth control pill. And then other risk factors, obesity, smoking, further increase that risk. So if you're going on the pill, it's preferable that you're not smoking. We won't give it to a smoker 35 and over because their risks get too high, but that's something to be aware of. Generally, there are 28 pills in a pack, and it's probably the most common option that women avail themselves to. Emergency contraception, Plan B. Some folks may have heard of it or used it in this audience. And basically, that's somebody who has unprotected sex who is not on contraception, but if they use this within 3 days of what we call coital event, that one sexual encounter, it has a significant efficacy in reducing the chance of getting pregnant. Some theorize that that burst of progesterone prevents the egg from ovulating. There are others that theorize that it prevents implantation of the fertilized egg. I think that's still debate on that, but that's generally not a preferred method because it has a higher failure rate than all the others. It has about an 80% efficacy rate. So Plan B is better than no plan, but you probably shouldn't be using this as a form of contraception. The patch, the ring, Depo-Provera, again, it's non-oral forms of hormonal therapy that work quite well. Depo-Provera is great for people who may have heavy periods as well. If they're concerned about weight gain, they may not be all that interested in it because it's a little bit of a higher on the weight gain scale. NuvaRing, I like it a lot, although we don't have a lot of takers for it. I think some folks just don't like the concept of putting in a tampon or putting in this little flexible ring, but it is essentially the pill in a transdermal formulation through this little ring in the vagina. And the LARCs we touched on, these are, Nexplanon, progesterone-containing IUDs. My favorite actually is the IUD Paragard, which is a non-hormonal one. The non-hormonal IUD works by creating what we call sterile inflammation in the uterus, a little T-shaped device like this. It's inside the uterus. And it's theorized it works by not only mechanically blocking sperm from meeting up with an egg and fertilizing it, but it creates a hostile environment for sperm. Interestingly, the IUD was developed in the Middle East centuries ago when folks going across the desert didn't want their female camels to get pregnant. So they would have an unlucky individual place stones inside the uterus of the female camels, and proven to be a very effective way of preventing pregnancy. I don't know if it was a very effective way of being safe for that individual, but that's the advent of the IUD technology. The Mirena and the other progesterone-containing IUDs, we do put them in a lot of young women who may have crampy, heavy periods and are looking for long-term contraception. So it kind of serves two purposes. Maybe about 25 to 30% of women on this IUD get no period at all. Technically, they're getting one, they just don't see it. They get like a cramp one Tuesday a month with a little bit of mucus, and that's their period. And a lot of people are real happy after the first month when they check their pregnancy test to make sure they're not pregnant. But there might be some hormonal side effects to that, breast tenderness, irritability, but it's fairly well tolerated. I already mentioned my likes and dislikes for Nexplanon, but it is very effective. And again, it lasts for 3 years. A quick office visit and injection, they put it in to get it out. It's a little tiny incision in the arm, and it's pulled out with a little clamp. But there are those who use it a lot. And that's just basically the anatomic representation of the IUD. There's a little string that comes out so patients can kind of put their finger in the vagina, feel the string to reassure themselves, oh yeah, it's still there. If somebody has an IUD and they put their finger in the vagina and they can't feel the string, then they need to come see us. Sometimes it means the uterus kind of rejected and pushed it out. A lot more often what happens is these strings just kind of migrate up into the uterus, but a quick ultrasound will tell us all good, you can go. But IUD has a very low failure rate, as does the pill, both of them under 1%. We talked about this one. That's the Paragard. It's made of copper and a plastic base. There we go. So I've covered my one colleague's lectures. So we'll go to the next, which would be sexually transmitted infections. And again, I'm not going to belabor some of the more serious ones because there's whole lectures unto themselves. But we'll get started. Obviously, as the name implies, these infections are transmitted through skin-to-skin contact, through mucosal membrane surfaces, so oral or anal or vaginal intercourse, and that's how they're transmitted. They can be either viral, bacterial, or what we call protozoan or parasitic. Risk factors: multiple sexual partners, same sex with somebody who already has a known STI, which wouldn't be really wise, but we have to mention that. Or IV drug abusers also are known to be have a much higher risk factor for carrying sexually transmitted infections. The most common ones, as you can see the menu of options here: chlamydia, gonorrhea, HPV, which Dr. Patel already discussed, herpes, trichomonas, syphilis, hepatitis B, and HIV. So chlamydia and gonorrhea, they're most common bacterial sexually transmitted infections. Trichomonas, which is more of a protozoan parasite, is actually the most common, but these two are the ones we worry about as gynecologists in young women. Unprotected sex, the women often come away with no symptom other than they might notice a little bit of a discharge, or their partner, if they're responsible, may give them a call saying they're having symptoms or they've been recently diagnosed. But the symptoms can be a yellow discharge, pain with urination, or bleeding in between periods. We can test this a variety of ways through a urine test nowadays, which wasn't available that long ago, or a vaginal culture. All women 25 and under should be treated. Simple treatments with antibiotics fix these things. And their sexual partners need to be treated as well. And usually we have to report these infections to the state. It's blinded. Now, we don't give attribution to who had the infection, but it's a public health matter. It's important to treat these infections even if you're not having symptoms because they could lead to fertility issues. Something called pelvic inflammatory disease, which can be an acute situation where a woman could have fever, lots of lower abdominal pain and cramping, like a really bad period that doesn't go away, riding in a car, going over bumps, you feel it. People can get quite sick with PID or pelvic inflammatory disease. Usually the onset of this more serious complication is within 48 hours or so of sexual intercourse with unprotected sex. Treated promptly, usually you're fine, there's no sequela. If left unchecked, it could become an abscess and you can get very sick, as well as it could damage your tubes and render you infertile. So real important just for your annual exams. If you're just carrying chlamydia that's untreated, you don't want to wait for the day where it starts as a lower urinary, a lower pelvic infection and ascends into what we call an upper pelvic infection, or PID. HPV, Dr. Patel covered this quite well. As I like to tell my patients when they ask about HPV, there's a royal family of HPV, about 14 different viruses that are the most virulent, and the king and the queen of that family is HPV 16 and 18. Those two are responsible for about 80% of all cervical cancers that develop. So that you're not scared, HPV is not real good at promoting cervical cancer. In other words, 70% of the population of US women have HPV by the time they're 30. A very small percentage of that population actually ever progress to more significant lesions on their cervix or cervical cancer. So not to be alarmed, but you should be informed and aware and get your checkups. Okay, herpes, a common cause for concern among the college population. There's types 1 and 2. A lot of times as kids, we may have had a little fever sore. That is herpes. Genital herpes is herpes type 2, but about 20% of genital herpes is type 1 because people have oral sex. So somebody with a fever sore in their mouth can have oral sex with somebody else in their genitals. That's where you get the flip-flop. The culture is important. The culture is the way we diagnose herpes also in the setting of clinical lesions. Usually they're little clear blisters that ulcerate, and they usually come back in the exact same spot because they live in the nerve. Somebody may draw a blood test on you and show antibodies in your blood to herpes. That doesn't mean you have clinical herpes. That means your body has been exposed to it, but you may have never manifested it. So it's an important distinction to make, because some folks may come in, they had a blood test by somebody and say, oh, I have herpes. Doesn't necessarily mean you have clinical genital herpes. The symptoms vary, but generally the presentation is you feel a little flu-like, feverish, and then you have these outbreaks of these clear blisters either on your genitals or around the lips or the mouth. And they last anywhere from a week to 2 weeks, very painful in the initial outbreak. There's an antiviral called Valtrex, and there's some others as well, that are fairly effective in not curing it, but reducing the symptoms and the time that the lesions are out. And then going forward in time, recurrent outbreaks tend to be in the same spot, and you tend to get a little warning. So if you can pop your Valtrex or antiviral, when you get the warning, it may stop the outbreak altogether or at least blunt it. Stress and sunlight are the number 1 and 2 causes for recurrent outbreaks. So final exams, you're studying out on the lawn of this beautiful campus. That could be enough to trigger a herpes outbreak because you're stressed for your finals and you're getting lots of ultraviolet rays from the sun. So note that well. Trichomonas, trick, known for short. Tough diagnosis to make. Basically, patients may come in with a foul-smelling discharge or just a discharge that gets foul-smelling after unprotected sex. It is very common, hard to diagnose. We do what we call wet mount. We look at under a microscope to look for these little tadpole-looking type bacteria that at 40 to 100 power we can sometimes see. Other times we're not so sure. There is a DNA probe test that we use now. It's been more helpful. But trichomonas is one of those what we call ping pong infections. If your partner doesn't get treated, and if your partner has another partner and doesn't stop visiting that partner, it's never going to go away. So it's just another good case for wearing condoms, all the time. If you have a partner, no need for that partner to know you're on the pill. I'd say a pill and condoms is the best protection. The pill for prevention of pregnancy, the condom for prevention of pregnancy and your own sexually transmitted infection. And then a single dose of something called Flagyl fixes the infection, but you have to know you have it and your partner should be informed. Syphilis, fortunately not something that common in a population in this demographic, but it is a serious infection. There's stories throughout history of leaders who did well until they had tertiary syphilis, which starts to attack your blood vessels and your brain, and you can go crazy. I think it was Al Capone was one of the most famous syphilis patients. But it starts with what we call a chancre, or a little like ulcer on your genitals. Usually it's a painless ulcer, and then that goes away, and then you can get, in the secondary stages, flu-like symptoms and a rash, and then it goes dormant for a while. During these first 3 stages, you tend to be still infectious if you have sex with somebody else. And then the late stage, or tertiary syphilis, is when people start to manage. They can have aortic aneurysms, they can have blindness, as well as they can become psychotic because it eats away at their brain tissue. There's a famous story in medicine about a guy named Poor John Hunter. He wanted to see what would happen if he injected himself with syphilis, and then he documented his decline until he could not document it anymore. But Poor John Hunter. It's a sad story of medicine. Treated early, curable. And also a note of caution, some folks who may have a collagen vascular disease or autoimmune disease can have false positive tests on the screening test for syphilis. So if you're told you might have syphilis, don't panic, get the more confirmatory testing. Hepatitis B, again, this is a common sexually transmitted disease worldwide. It is usually through sexual intercourse, although you can get it from fomites, as we discussed earlier. This is one of those more hardy viruses that can be picked up through other means besides just sex. But it does, it's an inflammation of the liver. You have flu-like symptoms, you turn kind of yellow, and it can promote more chronic debilitating conditions of the liver. There is a vaccine for hepatitis, so that's, I think all of you probably have to have it, right, to enter college. But you should be aware of it, but most of you are probably immune to it. And HIV, the big kahuna of all the STIs. Fortunately, when I started my training in medicine, this was a death sentence within 6 to 12 months. Now it's a chronic disease due to all the research in antivirals. But still, anybody who's sexually active in America has some risk factor for contracting HIV. Of course, knowing your partner is important and their habits. Somebody who's within the drug community or is an active user of drugs, even if they're not an IV drug abuser, they may be cavorting and having sexual contact with ones who are. So it's a condition that attacks your white blood cells and makes you compromised to fight off infection. So it's important to get checked every year when you go to the doctor. I advise patients to get checked for it just because it's always best to be safe rather than sorry. And I think I'll end it there because HIV, again, is a whole nother talk. But we'll move on now to the highlight of tonight, Dr. Anne-Marie Tang, a Drew alumnus and a OB/GYN physician, is going to talk about careers in healthcare.
Hi, everybody. Okay, so as a segue, I like segues. My favorite STI to see or to diagnose is trichomonas because it does have flagellae. And so any bio majors out there, you can see the little swirling flagella. Okay, so on the top, there's a couple of careers that I wanted to talk about. So if any of you are interested in any of these specifically, just let me know. You can raise your hand when I get to the slide so I can tell you more about it. So the slides I have are medical technician, physician assistant, nursing, health informatist, and clinical analyst, office manager, and physician. But of course, there's so many other careers, EMT, medics, social workers, almost there's so many different careers in the hospital too. Peace Corps volunteers as well. So in terms of a medical technician, basically you're helping the office staff answering phone calls, answering questions, helping the doctors take vitals, doing paperwork, collecting fluid samples, urine pregnancy tests. And then for this field, you don't need to have a bachelor's degree. You can have a high school diploma, GED, and then you would have to do a program of 9 to 12 months or up to 2 years, and then you would have to get a certification, so do an exam. And then their starting salary for that is about $30,000. On this graph, you can kind of see, so the type is a little bit small, but medical assistant is all the way to the left, and then dental hygienists, dental assistants, LPNs, which are types of nurses, and nursing assistants. Okay, and then this is also kind of small too, but this also goes over some of the salaries. So for a dental assistant, it says about $30,000. There's pharmacy assistant as well. And then as you work your way up, so registered nurse, the average salary is about $60,000. Nurse practitioner, I think it says about $80,000. And then doctor physician is about $150,000. So of course, with the salaries, there's more training involved as you move up through the numbers. Okay, and then this is another graph about the salaries. Okay, and then the next topic is physician assistant. So this one, you would have a bachelor's degree, and then you would need a 2 years master's on top of that. And then 2,000 clinical hours. So you would have to pass an exam. If you wanted to do specialization within the physician's assistant, so orthopedics, you would do additional training on top of that, and then you would be certified every 6 to 10 years. Another career is a nurse. So within the nursing realm, there's so many different areas you could pursue in. So if you were to have a bachelor's of arts degree, so such as if you went to Drew, you would then do an accelerated bachelor's of nursing, which is an extra 1 to 2 years, and then take an exam, or you can do a master's in nursing as well. You can also do a doctorate in nursing, and then you would get a license every 2 years. And then within the nursing degree, I do want to talk about midwives and anesthetists. For midwives, the average salary is about $90,000. So for OBGYNs, we work a lot with midwives, and so they can do vaginal deliveries. They don't quite do cesarean deliveries or C-sections, but they can be in the operating room and helping, but they can't be like the first assist to the physician. So that would be extra training, a master's degree, and then a nurse anesthetist. So the starting salary is about $100,000. The median salary is $150,000. So they start with sedating patients. So because there's a high risk involved in that, the salary is much larger, or a higher number. And then I do want to talk about health IT as well. So anyone who's interested in technology, there's a big movement to employ people to help with medical records, getting information, collecting data, doing research. So for this, the average salary is about $86,000. Finally, I want to talk about office management. So this would be supervising the nurses, the medical techs, the doctors, looking at budgeting, revenue. So this, actually, I pulled this information from a job listing. So you do need a bachelor's degree or a graduate degree of an accredited 2-year business college. And then this one job listing asks for 10 years experience. And then finally, because we are physicians, this is the most comfortable topic. So first you have to take your MCAT. So after graduating with a bachelor's degree, you would take an MCAT. Then you would do 4 years of medical school. Within the medical school, there's 2 years of lecture, usually based areas of study. And then after that, you would do your clinical rotation. So that's about 2 years, and you would spend 2 months usually about 2 months in each rotation. So internal medicine, OBGYN, surgery, psychiatry. And then after that, depending on what residency you would want to go to, it's 3 to 7 years. So pediatrics is like 3 years, neurosurgery is 7 years, OBGYN is 4 years long. And then after your residency, you would get board certified. So it's an exam, both written and oral. So most of this information from the slides is from this one website, www.learnhowtobecome.org. And then this is just what the website looks like here. And then in terms of just for myself and my path. So let's see, I graduated from Drew in 2010. Then I went to Rutgers Medical School for 4 years. And then right now I'm doing my residency at it's Rutgers, New Jersey Medical School, so that's also 4 years long. And then after that, you can either become a private physician, join a practice, or you can do a fellowship. So a fellowship is an extra 3 years on top of that. So I guess in total, it's about 12 years of schooling. So if I were to go back, and if somebody had told me this lecture beforehand, I would seriously consider either nursing or physician assistant. After you finish medical school and you start your residency, then you would get paid a salary. So usually the starting salary is about $50,000, depending on where you go, and then it increases about $3,000 or $4,000 per year. And then once you get to the attending status, so after you complete your board certification, it can be up to $150,000 to $250,000, depending on where you go. Usually the starting salary is a little bit, on the lower side. Loans, oh goodness. Okay, so I don't know how much the starting for here is annually, but when I was here, it was about 50,000, 60,000? Okay, so times 4, right? Okay, then medical school is about 60,000 per year. Depending on where you go, so I went to Rutgers Medical School, which is a state school. It's a little bit cheaper. And I live in Whippany, New Jersey, so it's a little bit cheaper in that sense. If you went to Penn State, of course, you would have to pay out-of-state tuition. It's kind of like undergrad. So that's about 60,000 a year. And then once you start your residency, then you start getting paid, which is nice. Do we get free healthcare? No, I do pay about $136 a month. Not that I'm counting, but yeah, you do have to pay. So you could pay for medical, dental, prescriptions, and then usually they offer you a plan, so you can choose which plan is right for you. So if you say you want to do a lot of, like you want to see your primary physician, you want to see an OBGYN, you can pay for a plan where you see them regularly, or you can pay for a plan that you would say like, if I really needed to see a doctor, I'd rather go to the ER. So depending on like what type of healthcare you're looking for, you can select a plan. I think it's helpful. I think that influenced me on becoming an OBGYN, and also because of my friends, they asked me for advice in terms of contraception. So for me, that was an interest. I mean, we're supposed to see.
I might want to interject. I can't resist. There's an old saying in medicine, those who treat themselves have a fool for a doctor.
So one of my favorite professors or lecturers gave a lecture recently about cervical cancer. So like he was giving a lecture to OBGYN residents, and so his first picture was like cervical cancer, and he was like, I hope this is motivation for you to see an OBGYN, because I'm sure most of you are not seeing OBGYNs regularly. So, even as an OBGYN, you may not see your doctor every year as you're supposed to. So at Drew, I majored in neuroscience and French. So one of my mentors here was Dr. McKittrick. I know she's still here. And I know she does a lot of women's health. So for me, that was really influential, and I did research with her as well. I did like looking at sleep studies and psychology in terms of rats. But I guess I also really like Dr. Denaway's microbiology. I don't know. It's just, the material is really dry, but he makes it very entertaining. So for me, that was a really important class in my decision to pursue. If you were to take a gap year and you're interested in midwifery, what should you best do? Okay. I think a lot of people have the misconception that you need to do something science-related with your gap year. I think a lot of people are looking for candidates who are doing more social issue improvement. So for me, I would say like if there's anything that really interests you, such as for me it was Peace Corps or something like that, that's really good to have on your resume. If you were to pursue something like if you wanted to do lab research, then maybe you should do lab research. But for you, I would say, find something that you're really interested in, something that you can talk to other people about. And so usually interest is contagious, and it looks really good on your resume. You're welcome.
We have some questions that were written down and handed in. So, go ahead. The question is, are there any negative side effects to getting a pap smear?
So I would say, besides what Dr. Abishow said, that it could feel like pressure and uncomfortable, I would say there's no side effects I can think of. If you, the reason I said we start pap smears at 21, it's thought that if you get a pap smear earlier than that, sometimes you'll, if it's abnormal because HPV is so common, you might have to do some other tests and that can be invasive. So that's the only other side effect I can think about, but not any else otherwise, besides a little uncomfortable, not a side effect I can think of. I don't know if anyone else can
No,
think of something.
but I think it's important to point out here, because I think medical history helps us remember how far we've come. George Papanicolaou in the 1920s invented the pap smear, which is basically scraping some cells off the cervix, looking at the patterns, and you can see precancerous growth. The most important cancer screening test ever in the history of medicine. So I think 100 years down the road, George Papanicolaou is still affecting women's health. Although going forward, I believe HPV testing will be the new pap smear of the future.
Is there something that you've heard that you're concerned about? Yeah, why don't you tell us that? No, it's not even really skin, it's almost
Mucus membranes,
mucus
yeah.
membranes.
Like the inside of your mouth.
It's almost like when
Yeah.
your lips are chapped or something, and, but in this case, you don't have to put any lip balm or anything, it's just gonna naturally go back, you won't even know it, So no, not at all, if that was your concern.
I'm going to take a couple of the questions that were written in, so those folks who didn't want to raise their hand, we can address them, and we all have a couple of them. If you want to share one with Dr. Tang, it'd help her. I've been on the pill for 3 years, but switched in October. I get my period for 4 days between packs. Is it normal? The question is, the answer is not anymore. In other words, when you make a switch or start a birth control pill, we give you about 3 months for your body to get used to it. So mixed up bleeding, unpredicted, or what we call breakthrough bleeding, is considered normal in the first 3 months, and we encourage patients to kind of live through it. After you get into that 4th pack, it should be perfect. And if it's not, it doesn't necessarily mean there's a problem. It could mean that, but really what it means is your pill pack is probably does not have enough estrogen in it. Estrogen kind of keeps the lining of the uterus stable. And in some women, they may metabolize estrogen a little quicker than others. So the first thing after an ultrasound to make sure everything's okay might be to either take a pill holiday, get off the pill for a month or two, or switch to a formulation that may have a little bit more estrogen or a weaker progesterone. So it doesn't necessarily mean it's a problem, but after 3 months, it should definitely be evaluated.
So someone asked if taking birth control on and off inconsistently is bad. Just to piggyback off that, I think it depends on what you mean by on and off. So if you're on it for a year or two and then you're not in a relationship, you decide to come off of it for a year, I don't think that I see anything bad with that. But if you're on it for a month, off of it for a month, or on it for 3 weeks, it's not that it's bad, but you're gonna have funny bleeding, your body's never going to get used to it, you'll have side effects without the benefits. So I think that might not be a good idea to be on and off, every month or two. But I think if you're on for a few years, off for a few years, I don't see a reason that would be bad.
It says, I just started birth control 2 months ago and I'm bleeding in between packs. Is this normal? So it's exactly what Dr. Rubino was saying. It's okay. You can do that for 3 months and then we would want to evaluate you if you still are doing that for another month. That's sort of the initial process of starting the birth control. Your body will do that.
You want to say? And one of the things I would say is make sure if you are having that problem, you're taking it every day at the same time, because one of the most common reasons that happens, besides the first 3 months where you need to get used to it, is people are not taking it consistently, you're taking it at different times, you're missing a pill, whatever. That's going to make it more likely that you're going to have that funny bleeding, and that then no matter what pill you're on, that's not going to get better then.
And by the way, there's a common misperception that if I want to have a baby, I have to be off the pill for at least 3 months or 6 months. No, it's out of your body basically in 24 hours. That's why you have to take it every day. And sometimes if you're on a very low dose pill and you miss it, you could conceive. So the pill is metabolized quite quickly in humans, so it doesn't have a long-lasting effect. question here, how would you go about further education after your bachelor's if you want to work abroad? Not sure if that means if you want to work in healthcare abroad or you want to, get a job and take courses to further your study. In the latter scenario, it's probably a little bit problematic if you want to go to medical school in say, Europe or anywhere outside the U.S. A lot of times there may not be training in different countries, and it's also reciprocal. Like if you train in the U.S. and you want to be an attending physician in Europe, they may make you go back for some training there. So it's kind of difficult to do medical training outside the U.S. and apply it back in, but I think it looks good for anybody's resume applying to medical school to show, diversity in their studies, especially non-medical. Study art history or religion. I think one of the most important things in medicine is that you really need to be kind of a person of the world and not just be a science-focused person. So I would encourage that, but if you're looking to apply credit for your for medical school or training by working abroad, that may not be the best idea. I don't know if any of you guys want to add to that. That's a great question. I think, healthcare policy, maybe that's what I'm hearing. Those are almost areas you migrate towards. One of the best things about medicine, it gives you great looks at lots of different things. You can go down the rabbit hole of research or academics or private practice or healthcare policy. I fortunately in my life became involved in public health I was the president of the Board of Health in the town in which I live. And that was a great experience. I learned a lot about population health. I sit on the board of directors at University Hospital in Newark, and there's a lot of public health policy as well as just healthcare policy within the institution. So that's something that you may not have time for when most of us are so busy taking care of patients. We don't really get too involved in that because we're doing what we love, which is in the operating room or in the exam room, and that's like the best part of medicine. I mean, they always say, don't forget the one that brung you to the dance. Out of all the things I do, the most enjoyable thing I do professionally is face-to-face interaction with the patient. So I don't know if you have any other comments on that.
I mean, right now I work at University Hospital in Newark, so for me, there's a lot of social issues there that can be addressed. I feel like if you feel like you have the need to fix something, there are so many venues for that. Like for example, for us social work, for me, like I'm really interested in postpartum depression. So if there's somebody who, we send out like a survey after everybody gives birth. So if you score over 12, then you get referred to the social worker. And the social worker is actually our first person that the patient will see in terms of, do you have everything that you need in order to move on to support your baby? And then if the social worker feels that you may need something else, either medically, then they may refer you to the psychiatrist. As a physician, we can probably see if a patient is depressed or somebody that needs medical help, but in terms of the other aspects of somebody's life, I feel like the social worker in that sense can really do a lot for a patient and give them the resources that they need. What happens if you get PMS symptoms after getting your period? So PMS, for anyone who doesn't know, it's irritability, headaches, anything that comes regularly in terms of monthly cycles. So short story short, so menstrual cycles it's estrogen and progesterone. So any kind of rise or fall in that can affect the way that you feel, the moods. I would say that if the different mood changes affect the way that you feel, and either it affects your social life, you feel really depressed, then those are times when you should see somebody for help in terms of for treatment for depression. But you can have symptoms after getting your period. That's normal. And then the second question is, do you need a separate razor to shave pubic hair? Anyone want to answer that? Nope. Okay.
As long as it's not someone else's razor.
Is going from a heavy period off, not on birth control pills, to a light 4-day period on birth control pills, is that normal?
I would say it's normal, and it takes some people sort of months to get there, and that's the side effects they want. So I would say 4 days and lighter is a good thing. That's what you went on it for, and hopefully you're finding some benefit. We have women who are like in their late 40s who are not necessarily taking birth control to prevent pregnancy. They're taking it for that exact reason, and they wish that within a month they would get better that quick, you know? So I think it sounds pretty normal.
I see two gentlemen in the room. And actually, when I started my career, it was about 80% men in OBGYN and 20% women. Now it's the reverse, and I see that reflected in this room. Any questions from the gentlemen in the room? All right. Women's health care, by the way, fabulous field, just so you know if you have an interest. The question is, can you take birth control pills continuously? In other words, take the first 3 weeks of it, and instead of going to the last 7 days of what we call placebo pills, skipping those and going right to another active pack to delay your period for 3 more weeks. Any panelists want to take that?
Yeah, that is something that is routinely done. So for the woman who has that horrible period that you just never, ever, ever want to get it, you can do that. And then you don't have to get your period. The sort of the standard way to do that is to do your pills continuously for 3 months, and then do the withdrawal bleed, then get your period once every 3 months. And so you can avoid having that horrible, painful PMS period. You'll only get it 4 times a year instead of every month.
And I might add to that, just so women are clear on it, the period that you get on the pill is artificial. It is, the drug companies actually started the birth control pill with progesterone only. Early in test marketing, people were freaking out because they weren't getting a pill. So some smart pharmacologists said, well, if we add a little bit of estrogen, that'll build a little fake lining, and we'll withdraw, that's Dr. Abasels mentioned the withdrawal bleed, we withdraw the estrogen after 3 weeks, then they'll shed a little lining. It's entirely normal to not get your period on the pill over time because your lining thins out or you take it continuously. Whole different ball game if you're not on the pill and over time your period stops and you're not pregnant. That needs an evaluation. But not getting your period when you're on the pill, especially if you're doing it purposely, it's perfectly safe to do because that's an artificial lining to begin with. The question is, if you're taking the pill and you miss a few days, is it okay to kind of catch up and take the pills that you missed?
So if you're not doing it too regularly, meaning you're not taking your pill for a couple of days, you can always double up when you do remember. So say if you miss 1 day, you can double up on the next day and take 2 pills. But if it's something that's going to happen regularly, then you probably want to try a different form of birth control. If you're using birth control to prevent pregnancies, then even missing 2 or 3 days or here and there would make the pill less effective. So for that reason, usually I recommend getting an IUD. That way you don't have to remember to take a pill every day. Or like Nexplanon, something else, or a shot. Should I take a lot of birth control pill if I want to use it instead of Plan B? Okay, so the medication in the birth control pill is similar to the Plan B, but I would say that we wouldn't recommend that. Using different dosages of medication isn't great if it's not prescribed by a physician.
That's a great question. The question is, after age 26, the HPV vaccine is not recommended. And the answer is the original studies that were done, the population was done on women 26 and under. That's the only reason. I suspect going forward that we will expand the age group who can get the HPV vaccine, but the FDA is very stringent upon, they only approve the vaccine for the original population that was studied to get FDA approval. So going forward, because once in a while I do get a question from patients who've never been tested positive for HPV, hey, can I get the vaccine? My own personal practice pattern is if they want it and I don't have a good reason not to give it, I will allow them to get the vaccine because I see it doing no harm and it could help. But there are ongoing studies to see if they can expand the age group, but it's not technically not indicated after age 26. Any other questions or concerns? Sure.
I was just wondering, so in terms of your health center or student health, Do they supply condoms for free? Good. That's great. And then in terms of for women in general or anyone, if you are under the age of 18 or 16, you can visit a OBGYN to get contraception or birth control. So in case if any of you have younger siblings and are interested in that, they don't need parental, what's the word? Permission, yes.
So, assuming there's no further questions, I hope tonight was informative for you. I think it's important, going to conferences and things. A lot of times, just one little night like this, something one of these panelists may have said or a question you may have heard might change the course of your life or make you decide, yes, medicine's for me, or it's not for me. But I encourage you folks, since you're in these academic centers to begin with, to continue to go to little gatherings like this. I think they're very helpful. And if you come away with one little morsel that influences you or changes the way you think about things, well, then it was worth it. I hope you learned some things tonight. I really enjoyed this setting. Again, this Dr. Abbashouse, Dr. Priya Patel, and Dr. Anne-Marie Chang. I'm Dr. Robert Rubino. We're the Rubino OBGYN group. We have a satellite office here on Main Street in Madison, as well as 4 other offices in northern New Jersey, in West Orange, Summit, Clark, and Bayonne. And if you want to reach out to us further about careers or just questions, our information is here. But thank you for attending tonight. We really enjoyed it.
Sorry, we have one more question actually we didn't address. So the question was, what do you recommend for IBS or irritable bowel syndrome? So irritable bowel syndrome, in case you don't know, it's irregular constipation, diarrhea, upset stomach. Usually it's triggered by stress. So a lot of times we'll say you should see a specialist, like a GI specialist. Depending on whether or not it's anxiety triggered or stress triggered, then you may want to decrease the amount of stress that's in your life, just to answer it on a quick basis.